Good afternoon, everyone. Welcome to our town hall today on Friday, May 29th, 2020. An opportunity to get an update on things occurring hospital-wide at Hamilton Health Sciences, and also to dig in on topical issues that you've raised since our last town hall. Some questions that we have answers for today, and others that we'll be posting answers to on the hub if we haven't already. Of course, if it's something that directly impacts you and you alone, we'll send you a response as well by email. So we have a few presentations today with some of my colleagues here with me. I'm Aaron Levo, Vice President of Communications and Public Affairs, and I'll moderate our Q&A today. So a little bit of housekeeping. We'll do a little presentation and then a little bit of Q&A. When it does come time for the question and answer, you can use the chat function or the raise your hand function to type in a question, and we'll do our best to get to as many as we can today. And as I mentioned earlier, if we don't get an opportunity to answer your specific question, we'll do our very best to get a timely response posted on the hub or to you via email. So to kick things off, I'll turn it over to Rob McIsaac, our President and CEO, for a bird's eye view where we sit this week.
Okay, thanks very much, Aaron. Good afternoon, everybody, and happy it's Friday. Thanks very much for joining in on today's session. So today's town hall will focus in on service reintegration or the ramping up of certain services at Hamilton Health Sciences, and also our plan to, so that would include both surgical procedures as well as ambulatory clinics, all of which were, or many of which were paused due to the pandemic. Before we get to that, I'd like to take a moment to address the issue of pandemic pay. We've received many questions and comments from staff across the organization about when the pandemic pay directive will take effect and whether additional roles will be added to its scope. I know this has caused some tension among people working at HHS since the government first announced this concept of pandemic pay. I think it's important to say that from my perspective, from the perspective of the leadership group at Hamilton Health Sciences, all of our workers deserve to be recognized for the extraordinary efforts that have been made over the past 3 months. A letter from all of the HNHB CEOs was published yesterday, informing the provincial government of our position, which is essentially what I just articulated. But even before the publication of that letter yesterday, we've all been making representations to the government around this. The Ontario Hospital Association has also taken a very strong stance on this matter, that all hospital workers deserve to be recognized for the extremely great work that has been going on over the past 3 months. Unfortunately, at least for now, it's unclear precisely how and when the province will enact and clarify this directive. But as I said, in the meantime, I want you to know everyone working at HHS has the full support and gratitude of hospital leadership, and we will continue to advocate on behalf of our workers for equitable treatment. The COVID-19 pandemic continues to evolve. We recently saw an increase in positive cases in Ontario. Managing our curve will continue to be a challenge as the province gradually reopens. As a hospital, we have to continue to be flexible in the way in which we're operating so that we can respond to the presence of COVID-19 here in Hamilton and beyond. Unfortunately, as you know, our own people are not immune to COVID-19. Last week, we declared an outbreak among our staff in our COVID unit, 8 West at the General. I know this is very worrisome and a difficult event, especially for the folks who are working on 8 West, but for all of our frontline workers. I want to say for everybody working on 8 West, you have our profound thanks and gratitude for stepping onto the front lines of the battle and providing care for patients with COVID at HHS. Your dedication is amazing. We are all in your debt. The fact that this outbreak occurred despite everybody's best efforts really shows how sneaky this virus is. I know that our leadership and clinical teams have devoted most of the last week to trying to understand the situation, understand what happened, and to try to determine how we can make sure it doesn't happen again. As you might know, this week we received approval from Ontario Health to begin gradually resuming some ambulatory and surgical services. This will be a gradual process. We want to proceed cautiously, but nonetheless, it's great to begin seeing more patients across our hospitals after pausing scheduled care in March because of the pandemic. A few members of our executive team have joined us this afternoon to provide an update on and answer your questions about our ramping up our service reintegration plan. So with that, I'm going to ask Les Gauthier and Dr. Stephen Kelly to give an update on the resumption of surgical and procedural care. Leslie, over to you.
Actually, I'm going to say over to Dr. Kelly. He's going to start.
Okay.
Great. Thanks very much, Rob and Les. Yes, I'll start off. So as Rob said, we were actually in March break, and it was in the middle of one of our scheduled OR slowdowns when we got the order Directive 2 from the Chief Medical Officer of Health for Ontario that we should ramp down or cease all non-essential and elective surgeries. So we're actually, because we're in that slightly lull time, we were able to come together very quickly, the heads of service for surgery, the directors, the administrators, the managers in the ORs, and look at what we should be providing. And basically, we reduced our scheduled care by about 50% or more. What we did, the priority we were given was to obviously carry on with the emergency work. And then urgent work, and that was urgent work that if it was delayed more than 30 days would lead to mortality or morbidity to the patients. So in that framework, we did manage to continue with the majority of cancer surgeries, and we also allowed access to our regional programs, cardiac, neuro, spine, and vascular. They were reduced access, but there was still access for the high-risk surgeries to go ahead. And this was all done, as I say, with the surgeons involved and the managers and the teams, as well as an ethical framework that was worked out as to what are the procedures that should be done, must be done, and then what procedures should be done. So a lot of work came together in a very short period of time to ramp us down, and for which I'm very grateful for everybody who was involved in that. It was a truly team effort and just showed everything that's good about the staff that work at HHS. It was quite phenomenal. So that's where we were, and now Les, I think, is going to tell us where we are going to.
Right. So I have the better half of the story to share on behalf of the procedural work. So we have had a task force that's come together, and that task force represents work in the OR that we're referring to as surgical work. And then across HHS, we have a number of procedural areas outside of the operating room. They include endoscopy, the heart investigation unit, arrhythmia services, our minor procedure rooms, colposcopy, interventional radiology. So this plan is really representing a plan anywhere that a patient at HHS would come to for a procedure. So as Dr. Kelly said, we did bring the teams together, and our heads of service and physician leads were very involved in this plan. And the first question we asked them is, tell us what patients are out there that are on your must-do list that we're not providing care for right now that you really believe we need to provide procedural work. And as we worked with that team, we worked with the principal that we're breaking this into two buckets. The first 10% increase of activity that actually started yesterday would or could have an impact to inpatient beds. So across all of HHS, that's about bringing an additional 46 patients in to have a surgical procedure. The second 10% of the ramp up is not impacting beds. And as we've ramped up, we've done this plan to make sure we're working within our existing resources. And one of the most important resources that we work within is our bed capacity. So we wanted to make sure that we are working within the provincial directive of maintaining a bed occupancy as we've ramped up. So first 10% could impact beds, about 46 cases a week. The second 10%, we've asked our surgeons to do lists of only same-day home procedures. So again, prioritized by clinical urgency, but these patients would be expected to come in, have their procedure, and go home same day. So in a week, we're anticipating to grow across the 3 sites about 106 surgical procedures. And then to those areas that I spoke of in the procedural group, they are having varying degrees of ramp up, which will equate to about another 100 procedures a week happening for our patients outside of the main ORs. So I look at this as our initial stage of ramp up will provide care to approximately 200 more patients a week. If I can have the next slide, please. So what is really important, and the teams have really committed to as we begin this ramp up of activity, is they are still going to prioritize which patients for which service are the most clinically urgent cases. We have committed that all surgical services will have some access to OR time across HHS. So if I use the service of urology as an example, urology in the initial 10% were not increasing their OR time at the Hamilton General, but they were increasing their time at the Jaravinsky, and we're looking for the surgeons to work together and make sure the patients most in need went to wherever the OR time is available. And the last bullet here is the most important, and that is we've asked Rob to sign off on behalf of HHS that we are committed, that we are going to monitor our inpatient bed occupancy, the use of PPE, and we want to ensure that we continue to maintain our inventory of PPE. There are a number of drugs that not just for us in the province, but internationally are in short supply. And to no surprise, these are the drugs that are needed, most important to ventilate patients, but they're the same drugs we use in the operating room. So we have a plan in place that we're going to continue to monitor the use of these medications. And with the help of Dr. O'Leary and Dr. Sodchuk between the anesthesia and critical care teams, they're also looking at how do they manage to work within the drugs that we have available. We have been very conscious that blood products have been in short supply, and we've been following our standard work to make sure that we are conserving and working within the blood products available. COVID testing, and then most importantly, that we have our people resources to support the ramp up. So if I summarize on behalf of Dr. Kelly and myself, the teams did a great job. We ramped down to less than 50% of our activity across HHS. The teams have come together and have a plan to increase our activity to get us back to close to 70% of pre-COVID. But that plan is completely dependent that we continue to work within our beds and the resources to do the work. So on behalf of Dr. Kelly and myself, really sincere thanks. People have been absolutely phenomenal to try and make sure we're caring for those most in need and appreciating. It's been a very stressful time for everyone. So sincere thanks. So do you want me to hand it over? Aaron's gone. Okay.
Just a little slow on the draw with my mute button, but happy to hand it over now to Dr. Barry Lum and Bruce Squires, who are going to give us a similar update on our service reintegration for ambulatory or outpatient care. I think, and then we'll pause for some questions. So over to you, Bruce.
Okay, thanks very much, Aaron. And yeah, I will. So hi, folks. I'm Bruce Squires, VP of Women's and Children's Health, and along with Dr. Lum, had the pleasure of co-chairing our ambulatory care task force. So I'm going to speak to our slides today, but Barry is here with us as well to certainly to answer questions. So as in surgery, the ramp down of ambulatory care way back in March was really dramatic. It was driven first and foremost by the need to ensure we were able to protect the health and safety of you, our people, and then of our patients and families. And so in that context, essentially we went to this place where we limited visits, ambulatory on-site visits, to those that just could not be deferred and that couldn't be done virtually. And so again, the result really was pretty significant. Only 22% of our normal ambulatory care activity continued to happen on site. And you know, because that reduction was so significant in terms of on-site care, we were able to consolidate the 150 ambulatory clinics across the organization to a significantly smaller number, really only a few across each of the sites. And we did that, of course, again, to control the activity and really to equip us to best protect the health and safety of everyone. Really, the context of limiting physical distancing. And before you maybe go on there, yeah, as a result of that, we were actually able to move 70%. Again, this is an average across the organization of our visits to virtual. Of those, about 30% have been e-visits, and the remainder being mostly telephone visits. But to put it in context, just to give you a sense, that's 1,000% increase over where we were at the same time last year. So it's just incredible how much we moved to virtual care. Okay, let's go to the next slide. So it has been said that it's much more complicated to restart something than it is to wind it down or to shut it down. And again, given the 150 really heterogeneous clinics across HHS, I'd say this was particularly true for our ambulatory care. And so because of that, and because of relatively strict guidelines we got from the province that Les has already spoke to, we've planned the first phase of the resumption of ambulatory care activity to continue in those consolidated spaces and really to advance in small increments. So in this first phase, total activity that's going to happen on site in our clinics is going from around 22%, and again, that's an average, varies by clinic, up to 30%. Taking that a little bit more detail, for 91 of our clinics, so for a significant number of clinics, we're not actually going to see a change in on-site clinical activity. And that could be because they might have been a clinic that really wasn't able to wind down because of the nature of visits, or could be a clinic that actually has not had to do any on-site visits because they've been so significantly able to move to virtual care. And so in the initial ramp up, they don't actually have to change. So for about 2/3 of our clinics, there's no change in this initial start of the phase up. For 51%, those are clinics that actually were seeing around an average of 14% of their visits on site, and they're moving up to 30%. So for the clinics that are seeing an increase, it's a little bit more dramatic. As we've planned for this activity, we've done that by looking with the service leads and chiefs for the visits that could not be done, again, virtually, and those that had the most urgent clinical needs. So we used the ethical prioritization framework and looked for those that were really priority 2s and 3s in terms of the implications of waiting. So if I can go to the next slide, please. So, you know, this initial ramp up of on-site clinical activity, ambulatory clinical activity is really quite conservative. What that does is it allows us to confirm that we can operate safely for our people, safely for our patients and families, and also sustainably. So again, Les spoke to the monitoring of a number of factors, such as PPE. In our case, a really clear one there, really important one, is the ability to maintain physical distancing of patients in relation to what used to often be very crowded waiting rooms, and in relation to staff as they come into examining rooms. So we're going to evaluate the impact, the results of this initial phase of ramp up over the first several weeks. And from that, we're going to be able, from that evaluation, we're going to be able to make decisions about what the next step of ramp up can be. And what we would anticipate is small increments of growth as we determine that, as I said, we're safe and sustainable. Within all of that, there certainly is a commitment across the organization, and we're seeing it with clinicians, and actually to a large extent with patients and families, to continue and where possible to expand the use of virtual care. Again, that's where appropriate, and we have to recognize, and we've heard this strongly, that there's cases where virtual care is appropriate. There's cases where we really do need to interact face to face and have an opportunity for a true physical exam. So again, as Les did, I want to close at this point with a big thanks and a recognition to the folks that live this every day and have lived the dramatic change in your practices, in your interactions with patients and families from that ramp down, and now the desire to get back to caring for patients, but wanting to ensure that we do it in a safe manner. And so, that's going to be an ongoing discussion as this evolves. So thank you for your commitment and your support through that. So at this point, Aaron, I'll stop and turn it back over to you and to Rob to, I think, moderate questions.
Thanks a lot, Bruce. So we have an opportunity here for some questions, and there's 2 preferred methods, but of course 3 that you can use. You can raise your hand in the participants section, use the raise the hand feature, or you can type your question in the chat function. Although I know a lot of people use the Q&A function. It's okay, I'll monitor all of them. I know last time I even had people text and email me questions, so I'll monitor those too. So you can fire away and I'll do my best to keep pace. I'll take a quick look now. I don't see any raised hands. Nothing yet in the functions. Let's check chat. I do have a question in the chat function here. Give me 1 minute. From Minika Pai, do we have an estimated time for the guarded reopening of outpatient medical daycare at the General?
So it's less. Yeah, I'm happy to try and answer that question. So to help people understand, medical daycare at the General is a very small unit. It's actually moved homes a number of times over the last couple of years, and actually provides care to patients who need, outpatients who need things like iron injections, some blood products administered, some minor procedures like paracentesis. And it also serves to be the recovery and reception model for interventional radiology and MDU for transesophageal echoes. So right now, the physical unit of the medical daycare space, we're just moving into the old fracture clinic space, which is behind the ED. And we've been in conversation the last few days. So that space is still needed by the emergency department. They use it in an area for patients under investigation for COVID. So perioperative services is going to work with Deb Bedini's team in cardiac and vascular, and probably resume some medical daycare recovery reception in either the heart investigation unit, or if we can merge it into same-day surgery in PACU. Those discussions are underway. I don't think we have an immediate plan to reopen medical daycare as it was prior to COVID. We need the space on the site to care for COVID patients right now, or patients being investigated. But we'll keep everybody informed as those discussions and our next temporary plan comes to be.
Thanks very much, Les. One of the questions that came up, I know, between our last session and now, and is also reflected here in the chat forum, is about visitation and visitors and our visitors policy. I know it hasn't changed as of right now, but maybe, Rob, I know there's probably a view to have a coordinated approach across the region. Can you speak to a little bit about what the discussions have been and when we might see a reassessment of that?
Yeah, so I think that's a great question. I think it's an especially relevant question because as we start to ramp up some of these services, people frequently like to have somebody come with. So I'd actually just forwarded this exact question over to Les Gauthier, I think yesterday or the day before. Les, do you want to weigh in on it?
Sure. So our current practice right now for patients coming in for procedures is those patients are screened prior to the procedure. And if there is an exceptional reason, they have been bringing a visitor with them. So I don't speak English. My daughter comes with me, and that's been clearly communicated through the screeners. Likewise, for emergency surgeries, we have been allowing one person a post-op visit. I think we're all uncomfortable with that. We understand why we did it. Our plan going forward is we're going to try and get through the next 1 to 2 weeks of ramp up, and then bring to the operations committee discussions around visitors, learners, residents, family accompaniment into the ORs. And we'll bring that back to operations and have discussion at that table. How do we proceed? We need to remember in all those decision makings, we're worried about PPE, we're worried about risk of transmission, and equally we know we have a role as not just a hospital for patients, but the roles of families. We have an academic and a research role to also support. So conversation, I think, will be within the next couple of weeks with the clinical operations table.
I guess another question comes up that's come up between the last time and now, and I know there's some others that haven't spoken yet that are on the call that maybe I could point to for this one, is around screening and how I know that's an evolving situation. A number of staff are redeployed to support screening, which is very much appreciated, but how will that adapt as we move forward in terms of welcoming new patients into our facilities? And then also as other staff now have to pick up their previous accountabilities, will they be playing a dual role, or how will that change? I know Michelle Leroux, our Vice President of Human Resources on the line, has been playing a role in coordinating screening. Michelle, maybe you could start us off.
Thanks, Aaron. Yeah, glad to start us off, and then we maybe can ask Bruce or Wes or somebody to jump in. So you're right, we've been very thankful, especially to our Ron Joy staff, who've been great at helping us with our screening. A huge thanks to them. We're so grateful for the work that they've done over the last couple of months. We do have a plan as those staff are moving back to their prior roles. So we do have resources, luckily, from our redeployment list where we will be able to meet that need. We're also kind of looking at a more longer term approach to how we staff this, and there's some discussions underway because screening will continue for the foreseeable future. So we're looking at options, looking at what our other peers are doing across other hospitals also. But again, if I was to say one thing, it's just a thanks to all of our colleagues who've stepped up and helped us in this important work, making sure that we're all safe in our hospitals.
Yeah, maybe I'll jump in real quick, Aaron. It's Bruce. Just to follow what Michelle said and to directly address one of the questions. So we do expect and need in the foreseeable future that that our clinics are going to provide lists of patients coming directly to screeners on a daily basis, so that helps to facilitate the flow of patients and any accompanying family or caregivers into the hospital. We will also monitor very closely those numbers so that we can adjust the number of screening and even the location of screeners as necessary in the initial phase. So this is one of the key pieces we have to monitor as we move to resumption of services.
Thanks for that, Bruce. Well, I've got you in the hot seat. There's a couple questions in the chat forum related to our outpatient care at Ron Joyce Children's Health Center. One being, is the plan still to reopen Ron Joyce Children's Health Center on July 1? And then the second being around our ASD program, a very busy program with young children. Will we still be using virtual care as long as possible, or will we be looking to return patients on site for that program?
Yeah, and so maybe on that second question first, Les, Aaron, because it applies to not just to Ron Joyce. Yes, where possible and appropriate to the needs of patients and families, we're looking to continue virtual care across the entire organization, and that would include in the autism program. Again, as I said, as where appropriate for the patients and families and where possible. In the case of the Ron Joyce Center itself, there's not a firm date at this point where we are able to plan for reopening. That, of course, is subject to many of the things that we've talked about. In the context of that, though, the Ministry of Child, Community and Social Services has asked children's treatment centers like the Ron Joyce Center that we operate to increase the amount of virtual care being provided and to work up plans for the delivery of on-site care. And so that planning work can be underway, but we don't have a firm date yet. As soon as we do, we'll talk to the teams and to staff about that.
Thanks a lot. And as it relates to maybe our administrative workers or those that are working from home for a variety of purposes, Michelle, maybe I could turn to you on this one. I know it's still challenging. I think broadly speaking, office-based workforces are trying to figure out how to return some of their employee base to office environments. Can you speak a bit about where we're at in that thought process? And then alternatively, given it's not possible now, I know we've had a number of, we have supports for people to work from home and flexibility in that. Can you talk about how we're thinking from an HR perspective about giving people the opportunity to try and create a home office and live with this new reality of working at home?
Thanks, Aaron. So, you're right. It's a hot topic across all of the hospitals. There's a group of people coming together, not just HR, of course, IPAC, clinical expertise, coming together to say, how do we return workers and when's the right time to do that? So the HR team especially, of course, is very interested. They're working with this group. Also looking at our policy. So we have a remote working policy that existed long before COVID, and of course now needs some significant tweaking. So luckily, the VPs of HR across the hospitals in Ontario are looking at that, and there's some really great discussions about how our work may change for those who are able to work from home, remembering that we have a great portion of our workforce that are on site. So focus generally on making sure that everybody can return to work safely. And I think you'll see more coming up in the next couple of weeks, but again, a really big effort with a lot of expertise coming together.
Thanks for that. We have a number of questions. I'm going to maybe pose one more and then we'll move on just in the interest of time. And again, for those that we haven't gotten to, we'll endeavor to provide a response to you by email where it's possible, or post these on the hub. I know we've started a section of questions arising from our town halls that'll continue to we'll have a living record of the questions asked and the answers provided. The one I'd like to raise, just because today's topic was about the return of services, was around, I think, just generally how we're going to manage and protect surgical beds. What's the strategy to protect surgical beds to maintain surgical throughput, at the same time maintain medical beds and COVID surge capacity? I know even as we think about that, right, it's an evolving situation in the community. We'll have new patients joining the wait list, as it were, and it'll be evolving every day. So maybe Leslie and Dr. Kelly, if you could just reinforce some of what you were talking about earlier about how we're going to manage that bed capacity and also think about needs day to day.
Yeah, no, thank you, Aaron. That's a very good question. And as Les mentioned, as we ramp back up, there are the various things, and one of them being occupancy. And people may have wondered why we had this slightly strange 10% here and 10% there in our ramp up. Well, that was because we worked first on the inpatient 10% ramp up, and we became very aware that we could have a situation with the fluctuations that we might be unable to have inpatients come in. So we thought, how can we actually continue with some surgical activity if we did have that occupancy problem? So we went with that 10% of same day home. So we have the dual approach at the moment, and we would be able to go backwards and forwards between those. And we may find that in the next phase of the ramp up, the amount of same day home work is going to increase by more. and the inpatient may have to stay similar or only just increase slightly. So I think we do have the ability to respond in the plan we have and going forward, but it is going to be an issue for sure. Les, did you want to add anything?
No, I think sometimes we don't recognize how big some of the procedures are that we do at HHS in a same-day home model. So the majority of our endovascular EVAR work, so patients having, quote, their aorta replaced and going home later that day. We've started in the last year with our colleagues in orthopedics, and our surgeons are doing same-day home total hip replacements or knee replacements, so sorry. So patients having a total joint that, 5-6 years ago, they would have been in hospital for a week. We now do those kinds of surgery as same-day home. So I think it's important to recognize that we do have a very large component of surgical activity that is same-day home. And it's going to be a very fluid model of shifting OR activity as we need to respond to beds. I think our first commitment, and we understand it, is we need to be able to respond to an unpredictable COVID world. It's going to be our new norm, and we're going to have the ability to ramp up and ramp down surgical activity dependent on the beds. So we all have that accountability to try and make sure that we are trying to work within what we have. We also are trying to advocate with the ministry for more beds. And I don't know, Dr. Stevens, you're online if you wanted to speak to that.
Sure. Did you want to speak to about some of the external work and the advocacy, and then maybe I'll follow up after that?
Yeah, I was going to just say, we're working on this at multiple levels. So I think that everything that Dr. Kelly and Les have just said is absolutely true. But Dr. Stephen West, working with his team, and working with St. Joe's, have come up with some very good work to look at how we can add more beds in the community. So we've been able to accomplish that at St. Joseph's Villa, where we're sharing beds with St. Joe's, and those represent opportunities for us to decant more patients out of the hospital, again freeing up capacity to move forward with more procedures. But we're also working regionally and looking at regional assets across hospitals in HNHB, thinking about opportunities for hospitals to work collaboratively together to make sure that that there's no capacity that's going unused or wasted, that we're maxing out on everything we can for the benefit of our community. So it's multi-layered and complex, and we're trying to press on all of those levers to allow us to create capacity outside of hospital so that we can be freed up to do what it is that we're supposed to be doing in terms of providing acute and ambulatory care.
Thanks. Did you want to add anything, Wes, or is that clear?
That's great, thanks.
So I do want to acknowledge that we have still questions in the queue, some with specific details about screening, others about office space and how we might be amending our space, as well as related to staff who may have been in contact with COVID and their ability to traverse about our sites. We just want to acknowledge those are there and we see them, and we'll get answers posted. But in the interest of time today, we can't get to everything, so I need to keep us moving. You can also continue to email questions to the hhsnews@hhsc.ca. And again, we'll get a rolling roll-up of answers to questions on the hub. Thank you very much for all those questions that people did put to us. That was very nice, a good, vibrant exchange with lots of inquiries. So I'm pleased to introduce next, we have with us Vice President of Communications and Marketing from the Hamilton Health Sciences Foundation, Tamara Pope, to talk a bit about how the foundation is continuing to support fundraising for the care that we're providing. It's needed now more than ever as we go through the pandemic, and I know things have been tough in terms of physical distancing and trying to figure out a new way forward. So Tamara, over to you to talk to us a bit how you're adapting to this.
Thanks so much, Aaron. It's great to be here this afternoon. During the last few months, we've all had to adapt to new ways of doing things. You know, for the team at the foundation, we've continued to engage the community to support your work, but it's certainly not business as usual. One of the many changes the team at the foundation has made relates to our signature events. Mac Kids Walk and Wheel, which is our largest fundraiser for McMaster Children's Hospital and the Ron Joyce Children's Health Center, was supposed to be held on June 6th. So when we knew we had to pivot, we tried to think of a fun way to keep our sponsors and our supporters engaged. We didn't want to have just another virtual walk. So after reflecting on one of the highlights from last year's event, the mascot dance party, which was incredibly popular, we decided to ask our community to shoot their own dance video. By chance, we found a great song by a local artist whose kids happened to be Mac Kids, and so we threw out the challenge. Rather than a one-day event, we launched a campaign that now stretches from Mother's Day to Father's Day. We're encouraging the community to register, donate, and shoot a 30-second or longer video set to Tim McMorris's Just Feel the Beat, and then to challenge 5 friends to do the same. The videos and funds have been coming in, but we can always use more. It's a great opportunity to have some fun, dance, and fundraise, and you can check out the videos and all the information at mackids.ca/walkandwheel. We do have 2 more events coming up in the fall, and unfortunately, we've made the decision to celebrate the 10th anniversary of Strides for the General virtually. Details will be announced shortly, and for Illuminite, which comes in October, we have just a little longer before we need to decide how that event will take shape. So why do these events matter? Because we need to keep raising money to support your work and help make sure that you have the equipment you need. Remember, the government doesn't fund equipment or patient amenities. One of the other ways that we raise funds that we know is incredibly popular with all of you, and that's our 50/50 Winning Wednesdays staff lottery. And while everyone is excited about their chance to win more than $20,000 every payday, what many of you don't realize is how the foundation uses our 50% of the proceeds. The list of equipment on this slide represents just some of what we have bought over the last year. All of this equipment is meant to help you and the patients. By the way, each year we do an analysis of the breakdown of lottery purchasers and use that as a guide to determine how the funds are allocated towards each site. As I mentioned at the outset, we have continued to engage the community to support your work. Unlike patients, we need to go out and find donors by connecting with individuals, grateful patients, and corporations. Over the last few months, we have aggressively marketed and communicated with the broader community and our existing donor base about how vital it is for them to care. And showing they care has been amazing. The response to the COVID crisis has truly been heartwarming. The donations of food and PPE, which we helped facilitate, have been overwhelming. Those donations have come from individuals and corporations alike. And of course, the most important contributions are financial, as they help us buy the equipment you need. Just some of what we have purchased in the last few months is reflected on this slide. It has been heartwarming to see how passionate and appreciative the community has been for everything that you are doing on the front lines and behind the scenes. We'll continue to pivot and adjust our messages and our events, knowing how vital the funds raised are to you and our patients. We hope that you'll support our efforts as we work to support you. And on behalf of my colleagues at the foundation, our donors, and our broader community, we are incredibly grateful and thankful for all that you have done over the last few months and all that you continue to do. Thank you.
Thanks, Tamara, and to you and all of your colleagues for the support throughout the pandemic and always. So we have a bit of time here for celebrations. Rob, I'm going to put it back to you maybe for this agenda item, and I can assist here with what comes up in the.
Okay. Yeah. Thanks, Aaron. I think on any given day at Hamilton Health Sciences, there's probably 1,000 things, big and small, that are worth celebrating. And I think it's important for us to recognize our colleagues, our teams, and others that we work with, if they've done something that's worth recognizing. And this is a great platform to do it because we've got lots of people here. And so if somebody deserves some recognition, what a nice way to do it in the context of, about 500 people, I think, that we've got attending on this call. So I just welcome people to speak up using the raise hand or the chat features if you have a colleague or a team or anybody at Hamilton Health Sciences that's done something that you think is worthy of recognition, that you'd like to celebrate. I'm hoping this is something that, because I know that there's so many great things that happen, that we'll get lots. And so if you are doing this, hopefully it'll be concise to allow more people to follow after you after your remarks. So I'll pass it over to Aaron, and hopefully we get a few people volunteering to recognize others within the institution.
I know earlier, Bruce, you and I were talking about the work of our screeners and how just wonderful that's been to have. Did you want to give a shout out to that group?
Yeah, thanks very much, Aaron. Maybe what I'll do, I'll start out with a shameless plug for the mascot dance video for folks as well, just over there. But yeah, and Michelle called it out as well. But with the reintegration of services, that means that many of the folks that have been redeployed may be returning to their usual roles. So this would seem to be an important kind of opportunity to really acknowledge, celebrate, and thank the efforts of so many people across HHS who have taken on that role of redeployment. I'll just say real quickly, like in the pandemic, like we all feel like we've gone through change, right? We're all doing jobs that feel different from what they felt like 10 weeks ago. But if you think about folks who've been redeployed, that's talking about doing something completely different, often in very unusual circumstances, sometimes new, ones where you may have to face, anxiety and difficulty and challenges. And what I've heard invariably is that this has been done with professionalism, with dedication, and again, with compassion for each other. And so we really have to take this opportunity to acknowledge and thank everyone that's been redeployed. And at the risk of leaving out some of the roles, just highlight again, folks that have stepped in to be screeners, to support our resilient support teams, to work in long-term care, to work with the health, safety, and wellness group to keep us safe. And the list goes on and on. But at its core, it's a case of you, our teams, being resilient and doing what's necessary for the health, safety, and well-being of each other and for the patients and families we serve. So thank you.
Awesome. Thanks, Bruce. And I know, Kirsten, you and I were talking earlier today too, and there was a professional recognition day that you had mentioned. Maybe I could get you to give that shout out now.
Great. Hi, everybody. Thank you. So I just wanted to recognize Physiotherapy Month and Speech and Hearing Month as they come to a close for May. We have a number of professionals in both speech language pathology and the assistant roles, communication disorders assistant roles, the physiotherapists, and of course the assistants with that group as well. But these roles are so important to us with our patients at this time and even before COVID, as they address functional abilities of individuals, lots of quality of life issues, things that impact things such as gait, mobility, swallowing, having a meal, actually getting nutrition, looking at how people actually interact with their environment, interact socially. It is really about optimizing people's senses and strength and endurance that they have to just live their lives every day. So we know these roles make an impact on our patients all the time in their success of being able to transition perhaps back to community or alternative settings, but such important team members who are always at each other's sides, supporting family issues that might be arising and emotional issues that may be going on in the unit as well. So really important team players, and I just wanted to recognize those professional groups for the month of May. Congratulations.
Good, we've got a couple of participants with raised hands here. We have Denise. Denise, if we could get you to just go ahead. What would you like to celebrate? Okay, maybe we'll give one more chance. Denise, you with us? I can hear you now.
Yes. Oh, perfect. I just want to celebrate the employee health team, both the EHS nurses and the ability staff. I got the opportunity to work with this team, and they went from overnight having a small team of 6 nurses to all of a sudden being inundated with COVID calls and travel-related concerns, and having to have a large number of staff redeployed to their area to help them support that. And I was just impressed with how professional they were, the number of hours they put in and the work that they did. And I think sometimes, you know, people may not think about all this work that happens in the background, and I just think they're doing a really excellent job.
Thanks for that, Denise. That's great. And we've also got Andrea in the queue. Andrea Frolick. Andrea, did you want to go ahead?
Hi, Erin. It's Andrea. Can you hear me?
Yeah, we can hear you. Go ahead.
Fantastic. I would love to give a shout out to our psychospiritual care team. You may formally know them as chaplains, but these folk are all registered psychotherapists. They've been on the front lines through this entire pandemic. Psychospiritual care practitioners provide holistic care specifically around end of life and rites of passage. They have been in the rooms of patients dying of COVID who are otherwise alone and unaccompanied by families. They've been facilitating virtual visits with families and patients who are receiving bad news but can't have their families with them. They have created new rituals around honoring the memories of patients who die and around creating blessings for the PPE and the masks that we wear. They are incredibly courageous. They step into all kinds of high trauma, high stress, high suffering work with incredible resilience and heart and courage. And I also thank them for and acknowledge the support that they give to our staff to also maintain their resilience and to connect with sort of their hearts and souls in the midst of the challenging times we've all experienced. So a big shout out to the psychospiritual care team at all of our sites.
Awesome, thanks a lot. I also have in here recognizing the redeployed staff doing N95 fit testing, completing literally thousands of tests over the last 10 weeks. And then also 140 days CLABSI free for the NICU. So there you go. Congratulations to that team on that. Rob, why don't I turn it over to you for closing remarks?
Okay, thanks very much, and thanks all for your attendance today and for engaging with questions and with celebrations. That's great. I think if you didn't have a chance to provide some feedback or if you had questions that didn't get answered, please send them to hhsnews at hhsnews@hhsc.ca. And we'll make sure we respond to you. And I know we're a 24/7 operation. Hopefully folks have some chance to get some time off. And if it's Friday today, so if you get some time off over the weekend, I hope you get to have some time to regenerate, spend some time with your close family. So thanks all, and we'll be doing this regularly. So we'll see you again next time.